Hi, this is Chris with Road to a Cure, and I'm here with Dr. Phillip with the Karmanos Cancer Institute. And Doctor, thank you for taking your time today.
Thank you, Chris, for inviting me. It's a pleasure for me to be with you and to be part of the great project and the noble cause that you're working for.
We have a bunch of questions from some of our Facebook followers. Do you feel like taking a swing at some of these?
Sure, yeah.
Shall we wade in?
Yeah. So Kristen is asking, I'd like to know how quickly pancreatic cancer grows. Is it possible for someone to have it for years before it's discovered? Also, is it customary for someone to pay to participate in a clinical trial or in an experimental therapy? If so, are placebos ever given to someone who has paid to participate? Is there anything on the horizon that looks promising in terms of early detection? Pancreatic cancers grow on average over a number of years. When we diagnose a patient with pancreas cancer, the disease has been there for several years. However, because of the location of the pancreas and the lack of symptoms during its initial stage of development, patients in the majority of the cases, like more than 80% of the time, come to us at a point where the disease is more advanced. But yes, it's been there for a number of years or before it's discovered. Patients who come to us for clinical trials or go elsewhere for clinical trials do not have to pay for the drug itself or even its administration, because the drugs that we use in clinical trials are paid for by the sponsor. That can be either the National Cancer Institute or the pharmaceutical companies that provide the drugs. So in general, we really do not expect patients to pay for the treatments, and that's something which a lot of people have a misconception. So to be on a clinical trial, you shouldn't really worry about paying for it. And this applies to the other question regarding the use of placebos. We don't give placebo on its own usually. Placebo is often added to one chemotherapy drug, but it's rarely given on its own in clinical trials. And certainly you don't pay for clinical trials, so that's not an issue. Is there anything in the horizon that is looking promising? There are a number of drugs that are being tested. There is a drug called nab-paclitaxel, which is being tested in a phase 3 trial. And there are a number of other drugs at this time that look promising in the treatment of pancreas cancer. The question regarding early detection, we're still some years before we really get into the mode of the early detection of this disease, but there's a lot of work being done which ranges from having a blood test or having a scan, like a PET scan-like scan, to help the diagnosis. But these things are still being tested, so I'm not aware of anything which is really going to be available within the next year or two.
Is the placebo generally, in these kind of trials, a sugar pill, or is it a known drug with a known efficacy?
I think you have to distinguish between the placebo drug itself. When you say the drug is a placebo, it is a sugar drug. Placebo, by definition, is a sugar drug. It's a sugar, basically, or it's an inert compound. What you're trying to also explain, Chris, I think, is in clinical trials there is something called double-blind type of design. Double-blind is the doctor nor the patient know what really is being given. One of the drugs could be the active drug, and one of them could be the placebo. But when we say this tablet is a placebo, it's sugar. But it's separate from saying the study is a double-blind where people don't know if they're getting the placebo or like the sugar, or they're getting in that capsule the active agent.
So they truly could be getting nothing at all towards?
Could be nothing at all, but the convention is that we rarely give a patient nothing at all. Just to give an example, gemcitabine is a drug we commonly use in this disease. Gemcitabine is an IV drug given once a week, and for patients with pancreas cancer, it's very well known. If we do a clinical trial, we will say half of the patients will get gemcitabine plus another experimental drug, let's say X, gemcitabine plus drug X, and the other half will get gemcitabine plus placebo. So both groups of patients are getting the active drug, which is gemcitabine, but half of them, and they don't know who they are, and we don't know who's getting the experimental drug versus those who are getting the placebo. But both groups of patients, like everyone in the study, will be getting the active drug, but half of them, by chance alone, will be getting an additional drug to it. And the other half will be getting an additional pill, which is, or an IV, which is the placebo.
And I think that's really the heart of a lot of people's question about the placebo, is thinking that if I go into this trial, I may get nothing to treat my cancer at all.
That will be extremely, extremely unlikely that there will be a clinical trial in pancreas cancer. In fact, in most cancers, at least in this country, where people will be getting just sugar.
Let's see what Linda has to say.
Linda's asking, any new treatments for a recurrence? What about new tests for early diagnosis? Any alternatives to enzymes, since they are getting so hard to find? What are the long-term effects of the Whipple? And here, I think the thing is over 10 years. In terms of the new treatments for recurrence, the number of chemotherapy drugs, or the range of drugs that we can use, has been somewhat expanded, especially recently in June of 2010 in the ASCO meeting, which is the American Society of Clinical Oncology meeting. There was a presentation where a new combination of chemotherapy drugs also was shown to be active. So yes, we have now more drugs, chemotherapy drugs, that we can use, which is a good thing, which is an excellent thing. About the new tests for early diagnosis, I mentioned earlier, at this time, we don't really have a test that I could say, go and have it done, or recommend someone to have it done, something like a mammogram or a colonoscopy. We don't have that yet for this disease. Alternatives to enzymes, since they are getting so hard to find, I personally, I prescribe these drugs very frequently, but I haven't had patients complaining to me about not getting it, so I wasn't sure on Creon and all that. Yeah.
Yeah, Creon is still readily available, but the generics apparently are becoming hard to find out there.
Well, that's education for me. I thank you for this question. I truly do, because a drug that I prescribe a lot, and I'm somehow glad that I know that there are challenges for my patients about it. The long-term effects of the Whipple, there are some adjustments the body does, and I was impressed by the number of complications people had with Whipple. I had a patient who spent years before it started to gain weight again, but I think ultimately the Whipple procedure patients usually it's well tolerated. They do well, so I'm not concerned about the long-term complications as much as I'm somewhat still concerned about the immediate complications of the surgery and the intermediate complications. Issues with regards to diabetes, it can be worsened because you're removing part of the pancreas. That's a possibility. But again, that's something which, as you well know, it can be controlled by medications. But overall, a Whipple, a long-term problem is not debilitating for patients, the vast majority of the patients.